Dermatologist, IAC Chief Coordinator, NEET PG Dental Pulse Academy Coordinator and Chairperson of this session, and Dr. N. Kannan, Chandra Diabetes Care Center, Consultant Physician and Diabetologist, Chennai, and Chairperson of this session, to introduce the next distinguished speakers. Over to you, sir. Thank you. Yes, please put your hands together and give a warm welcome to both of them. Thank you.
Hello. Good afternoon, friends. Welcome to post-lunch session. Now we have very interesting topic on anaphylaxis. Friends, anaphylaxis is the emergency in clinical medicine where hesitation becomes fatal. So early recognition and early action is very important. For this to elude, we have our very enthusiastic and eminent speaker, Professor Dr. Vengadakrishnan. Sir is a professor of medicine from Sri Ramachandra Medical College. He is MD General Medicine from GR Medical College. He is a FRCP from Glasgow, fellowship in the College of Physicians. Over to you, Vengadakrishnan.
So thanks dccon, Natarajan and his team, Dhanamithran sir, for the opportunity given. So post-lunch is always a tough session to take. The first is you have a postprandial nap, you feel like sleeping, but this is a good topic. Maybe the organizer thought anaphylaxis is a very important topic. If you miss the boat, the patient dies. It can be near fatal. That is what is. So you may survive at sometimes, but usually it is anaphylaxis, it's fatal. So I just touch upon what is anaphylaxis and what we should learn as a clinical person. So I will not touch a pure theory, but a few aspects of anaphylaxis for a clinical knowledge you should know. How is it different? Anaphylaxis can present as a mild one in a very rare clinical presentation. So we will discuss on that. If left untreated, it is near fatal. I told you, it progresses rapidly. The most important thing is it causes shock and airway obstruction. That is why it is very tough to handle. So what triggers is most common is foods, followed by medications, insect bites. Patients will come, wasp bite, bee bite, or they will come and ask what is to be done. Latex exposure. The last one is there is no clear trigger identified. You don't have a clear trigger identified. So what happens in the first phase is with the initial contact with the allergen, the pointer is not working, no issues. So you have a pointer which is working. This one is working. Yes, sir. So with the initial contact with the allergen, what happens is there is an activation of various cells which mediates to IgE. IgE antibodies release the major culprit is mast cell. Through IgE mediation, there is a mast cell activation. So this one, why I put is, initially it may go as a mild reaction, but there is a subsequent contact with the same allergen, it goes for a severe allergy where histamine and other inflammatory mediators are released. The second slide is, what are the mediators? So if you know the mediators, why I should know the mediators is definitely histamine, as I told you. The target is, the treatment is antihistamines, specific antihistamines to target. Cytokines, chemokines, all from the stimulus and mast cell activation. Cytokine chemokines is taken care of by anti-inflammatory steroids, and when the patient goes for a shock, you have a specific molecule for anaphylaxis. Then is eicosanoids. Through leukocytes and macrophages, there is a protein degradation, phagocytosis, bacterial killing. If there is a good adaptive immune response in a few patients, that's what I told you, they may have a initial episode as a mild allergy, which goes unnoticed. So pathophysiology, it affects major systems. This is must know. The most important thing is respiratory. Upper respiratory, there can be angioedema. So initial aspect, what happens is the patient has puffiness of the eyelids or edema of the lips. That is the warning sign, the first warning sign. You should be doubly cautious if the patient has angioedema. Stridor occurs later. All this is because of histamine. Histamine along with leukotrienes, cystinyl leukotrienes. Leukotrienes causes severe bronchoconstriction. So severe bronchoconstriction causing significant hypoxia. Again, histamine can affect the digestive system. That is why when the patient has an allergy along with the GI symptom, you should be again careful. So you should not say because he had some food that because of that he is having gastritis. This GI symptoms in a patient with other contributing factors could be due to histamine. The next important point. Again, platelet activating factor along with leukotrienes with histamine. What causes next phase is hypotension, tachycardia, vasodilation, increased vascular permeability and syncope. So initial manifestation, as we told, is angioedema, urticaria, flushing. We learn with the case scenario. So this is important. What happens with the upper respiratory, which ultimately results in hypotension, tachycardia, vasodilation. So what are the modulators of? So if you ask me, the patient may ask, will I get a reaction? Very tough to predict. But if there is a family history, or there is one episode of anaphylaxis, post anaphylaxis, we can always work up the patient whether he is prone for further episodes. That's what we are going to discuss in this slide. What does it say is hereditary alpha tryptosemia. So any anaphylaxis, we do our angioedema 2 investigation. We do a C1 esterase inhibitor and tryptase levels. If tryptase levels are significantly elevated, the patient is at risk for further episodes of anaphylaxis. They should be on a long-term antihistamine and steroids as necessary. HLA-DR prediction, nothing we cannot predict. This platelet activator function level and can predict future onset of anaphylaxis. So anyway, this AC inhibitor, always you should bear in mind, the only drug that can cause angioedema even after 5 years. So any patient, Telma we are giving, most of the patients are diabetic and hypertensive or on telmisartan or enalapril in government setup. Now government setup is giving telmisartan for most of the patients. ACE or ARB, he says that I am taking ARB, ACE for last 2 years. Now I am having edema of the lips, and this is a idiosyncratic reaction, not dose related. It can occur any point of therapy. One episode of angioedema, you should stop ARBs. You should not tell that he is taking for 2 years, now only he is developing. You should, it's a clinical acumen that you should stop. It can occur at any point of the therapy. So others, NSAIDs we know, beta blockers, a few beta blockers can cause. So types of anaphylaxis, all we think is it is only immune mediated. It can be non-immune mediated. That's what is the learning for us. So what does it say is, we know, everybody knows Ig mediated anaphylaxis due to histamine. I am not going to full core theory aspects. Common theory is, you can see what are the, usually eggs, milk and shellfish. Nuts, peanuts. Now we are all fond of peanut butter. Not we are fond of, we are all grown up. All the adolescent and children and young individuals, they are fond of peanut butter. So we are seeing reactions to peanut butter recent times. Various, it could be due to various factors. Others we know, penicillin, insect bites. Non-IgE mediated, this should be, you should know what is this. Other parts of the immune system, that is IgG antibodies or the complements can be activated. So in this, antihistamines may not have a significant role if it is non-IgE mediated anaphylaxis. So non-immunological, there is something you may, if it's always immunological we feel, what does it do is, the immune system is not involved. It directly irritates mast cells and basophils, causing them to burst and release only histamine. There is no other immunological reaction. If this is the anaphylaxis, that is why a few patients within 1 hour, 2 hours it subsides with a simple antihistamine. So these are the patients where the immune system is not involved, only histamine release is involved. So this is usually with opioid or NSAIDs, extreme cold, heat or vibration, heavy exercise can rarely induce anaphylaxis, non-immunological anaphylaxis. Idiopathic anaphylaxis. What happens is, severe anaphylactic episodes are there, but you test for everything is negative. No trigger is identified, only by exclusion you can say it is a idiopathic anaphylaxis. The other is, this thing you should know is the phase of anaphylaxis. It is uniphasic reaction, biphasic. This biphasic reaction you should know. Somebody comes with anaphylaxis to the emergency, you should say, I am going home sir, nalla aidichi. You should observe the patient, ideally for 6 hours or 12 hours. If you feel the reaction is severe, at least 12 hours we observe, or you document at his request or against medical advice I am going. Otherwise, he may come with a severe reaction as the biphasic reaction. Initial, after 2 hours, it subsides. After 2 hours, the patient has a new trigger is there. It causes a severe anaphylaxis. That has to be borne in mind. Protracted is very rare in specific therapies. There is protracted anaphylaxis is seen with medications. So we don't see only in a tertiary care setup we see. But in a primary setup, be careful about this biphasic reaction. Observation is very important. To summarize what we learned from all immunology, pathway of anaphylaxis is type 1 or IgE or non-IgE. We have discussed that. Cytokine release, a mixed IgE, non-IgE plus cytokine release, only complement release. So why we should know this is, if this 2 and 3 and complement is involved, definitely steroids should be given. But clinically, initial phases, we always give a short course of steroids when we don't have an idea what is the exact reaction. So initial phases we don't. So tryptase and all, it takes time. Takes at least 3 days for the values to come. And IL-6, IL-1 beta and all, we don't do. Histamine levels we don't monitor. So what is done is tryptase, as I told you, and C1 esterase inhibitor levels. So this is the case scenario. Classical scenario what we see in practice is, a 24-year-old male with no food allergies is at a restaurant eating a Thai curry. Now all Chinese foods, all foods have become famous. So everybody prefers only non-Indian foods. So within 5 minutes, 15 minutes of eating, he feels a choking sensation. So no definite skin rash, heart rate is, tachycardia is there, BP is high, in the higher range, lungs clear. So what should be the next step? So reassurance, you give a thrust on the back, we call it cafe coronary. There is upper airway obstruction because of food impaction. For that you give a thrust on the back. You give injection adrenaline, you give a hydrocortisone or fexofenadine, Allegra. So what should be the ideal one for this patient? So you think it is anaphylaxis? It's not anaphylaxis. It's only cafe coronary. That's what you want to say. So, very important. This slide is an important slide. What happens 10 minutes past ingestion? These are the early signs. If you miss early signs, so you can miss the patient also. That's what you should know. What happens is a tingling sensation in the mouth and lips, generalized pruritus, followed by rapid onset of widespread urticaria and erythema across his chest and face. There will be erythema in the chest and face. Some patients can have eyelid edema and lip edema. 15 to 20 minutes post ingestion, what happens is he experiences upper airway obstruction. So any choking after a thai curry, all these Chinese foods contain what? Either they contain some glutamate related substances or peanut butter or various other substances which can induce anaphylaxis. Seafoods. This is followed by severe wheeze and shortness of breath. 30 minutes post ingestion, the patient goes for a hypoxia, severe hypoxia, hypotension. That's what in 30 minutes you may lose the patient. So we have only half an hour. And the patient has early signs, choking, better start treatment. So ideal treatment will be, so don't hesitate, give adrenal. That is the only life-saving medication in anaphylaxis. So hydrocortisone, definitely. Along with that, you always give, be safe. Fexofenadine is a supportive treatment. It's not for acute management, emergency management. It is definitely needed for histamine release. So assess the patient, should always auscultate the throat, trachea. You clear stridor visible, that is inspiratory wheeze. During inspiration there is a harsh sound, that is stridor. So all other findings I am not going to discuss. The patient goes for a profound hypotension, tachycardia and tachypnea. Clinical signs, initial clinical signs are stridor. That should be identified. As I told you, epinephrine intramuscular, 1 in 1000 dilution, 0.3 mg is the drug of choice. Immediately into the anterolateral aspect of the middle third of the thigh. It should be injected in the thigh, vastus lateralis, not in any other position site. So anybody wants to tell me, is there a role of endotracheal adrenaline? Yes. If the patient has shock, profound hypotension and hypoxia, you intubate the patient. In those settings, you have a hypotension, IM, vascular perfusion is not predictable. So you give a IM along with a endotracheal adrenaline as a life-saving procedure, because hypotension, absorption of medication, you cannot predict. So that is very important. Positioning is also important. Any anaphylaxis, the positioning is, it should be sitting abruptly during anaphylaxis can never happen, should never be done, can cause fatal cardiovascular collapse. It's always a recumbent position with his leg elevated to optimize venous return. It's the best position. So airway, high flow oxygen via a non-breather mask is applied, circulatory support, 2 IV lines, large bore IV lines should be established, and at least 1 liter of saline to be initially rushed to maintain the perfusion. So you follow up the patient. So with this we have an idea, we have done. Response to epinephrine, within 5 minutes of IM epinephrine, the patient's airway stridor decreases. That's what I told you. If the patient is in shock, IM epinephrine, if it is not acting, within 5 minutes the patient has to improve. That's also a clinical sign. So bronchospasm eases and BP stabilizes. A second dose is usually not required. If it is not improving, endotracheal. That is the best one. Secondary therapy is once stabilized, antihistamines and corticosteroids given to help mitigate the risk of a late phase reaction. That is why biphasic response will be there. After, there may have a biphasic response after 2 hours, 2 to 12 hours. Observation. So 6 hours mandatory observation. Now in this setup, always tell them you have to stay overnight at least 12 hours. I have to observe you. If a second reaction occurs, it is your call. It is at your risk. You leave. You should be very clear. So I think I summarized anaphylaxis. What are the pathophysiology of anaphylaxis? What are the clinical manifestations? How to treat, which is a must-know emergency for any private practitioners, be from a primary setup to a tertiary setup, whoever it is, we should know how to manage anaphylaxis. Any questions I will be willing to answer. We have 4 more slides on this. Why I put these slides is, not all allergies are anaphylaxis. First you should know. There is a difference between angioedema and anaphylaxis. What is the difference is, it is only a localized swelling, no urticaria, no hypotension, no systemic involvement. As I told you, ACE inhibitors are the culprit. Usual culprit if the patient is on ACE inhibitor or ARBs. The thing is, hypotension with multisystem is anaphylaxis. Isolated swelling without shock is angioedema. Why you should know angioedema is, one episode of angioedema can be a secondary reaction which can go for a severe reaction, could be anaphylaxis. The next episode. You should identify the culprit and stop. The second slide is, this is what is classical angioedema. You get lipedema and edema of the eyelids. This will be the manifestation. If only is localized, this localized, it's always easy. You give antihistamines. If it's a severe one, you can always give a short course of steroids. This is not anaphylaxis. This is a classic urticaria, hives we call it, raised lesions. Along with this, if the patient has choking, it is anaphylaxis. Diffuse rash along with choking is anaphylaxis. This is the last one. This is also a drug reaction. Why we should know what are the drug reaction? One more slide is there. Why you should know this is erythema multiforme. It is called target lesions. You can see there is a dot inside. Target lesions, usually in the palms, soles, it is seen. The last one is, this is Stevens-Johnson. So drug reaction should be there. Not all drug reactions are anaphylaxis. Anaphylaxis has a specific one. So mucus involvement, you can see diffuse mucus involvement, skin involvement is there. This is Stevens-Johnson. Why you should know is, this can progress to anaphylaxis. It's the next drug reaction if it is there, if at all it is there. One immune mediation can worsen the next episode of immune reaction. Thank you dccon for the opportunity. I will be willing to answer any questions.
Well,
Yes.
so,
Yes.
Dr. Vengadakrishnan sir, we have the questions at the final of the session.
Right, okay,
Yeah,
thank you. என்ன மேடம்? I'll tell you மேடம். நான் சொல்றேன் உங்களுக்கு.
So at the end of the session, we will be ending the question session. Now we are entering into the next topic. Again, a very interesting topic. Before that, we are mesmerized with our good orator, Venkadakrishnan sir. As expected, it was not theoretical, with a very clear case-based scenario of thigh curry. So how you are going to manage each and every step of anaphylaxis. And another interesting topic we are going to discuss, urinary incontinence. Everyone is able to see the patients of urinary incontinence. The problem is, the patient with urinary incontinence, we know how it is going to be suffering for them. But how we are going to approach the patient with urinary incontinence? Many causes may be there. It can be hyperactive bladder, atonic bladder, automatic bladder, or even BPH, benign hypertrophic prostate, pressing the urinary bladder. So many causes are there. So Dr. Mathisekaran, Thangarasu sir. So no need of introduction of him. Sir is a nephrologist at INO, urologist, kidney transplant and robotic surgeon at INO hospital. So sir is going to enlighten us on how to approach a patient with urinary incontinence, types and management. It is going to be a very interesting topic because many general practitioners are not able to manage the patient with urinary incontinence. They are doing a different treatment, but actual treatment should be different. So that will be enlightened by our urologist, sir. Back to you, sir.
Thank you so much. Warm welcome to everybody, and my sincere thanks and gratitude to the D Club, Dr. Dhanamithran, founder president, Dr. Nadarajan and Dr. Parandaman for inviting me here. I'm very grateful for this. I am Dr. Madhi. I'm one of the consultants with INO Chennai, and I look majorly into the functional urology aspect of urology. With respect to urinary incontinence, as medical practitioners, we would all have come across urinary incontinence, either in our own families or the patients or our relatives or friends, and this is one of the most common conditions we come across, yet most of the policies, most of the especially most of the programs kind of neglect it. The patients also feel very delicate to come up and tell that they have been suffering from such a issue. So it's been under-reported health condition, and it is also a big burden in developing part of the world. So as we discussed, urinary incontinence, we all know, it's involuntary leakage of urine. There are certain types that we should know before we manage the patients. In this slide, in this talk, we would touch about the types and how the patients present, and how as primary physicians we can manage these conditions, and at what point we may ask for help from the concerned specialist, be it a urologist, urogynecologist or gynecologist. So we would look into it. With respect to the prevalence in India, it's more common in women. We know that 2:1 ratio, and the incidence or the prevalence is around 12.5% in reproductive age group, and goes up to 45 to 50% in women who's more than 40. And the most common type of incontinence that we come across in practice would be stress urinary incontinence. We would very briefly look into the types of incontinence. And the major risk factors that we come across are childbirth and parity. Higher the parity and vaginal deliveries, the risk increases substantially. And chronic conditions such as diabetes, constipation, recurrent urinary tract infections are also associated with such conditions. Obesity, the global pandemic that we come across, is one of the most common causes for urinary tract infection, urinary incontinence. And obviously the lifestyle modifications that we are going to look into, they play a major role. So now coming to the clinical type of urinary incontinence. So there are, in our part of the world, we basically follow two major guidelines. One is European Association of Urology guidelines, and the other one is International Continence Society, ICS guidelines. So these two guidelines majorly stress on stress urinary incontinence, urge urinary incontinence, and mixed urinary incontinence. There are other two things that I would like to touch upon. One is overflow incontinence, and last but not the least is functional urinary incontinence. So the stress urinary incontinence is one where when a patient comes with a complaint saying that I leak when I have anything to do which increases my abdominal pressure, such as cough, sneeze, or laughing, or just bending down and picking up anything which increases the abdominal pressure. So that's stress urinary incontinence. And when somebody is coming and telling that, doctor, I have this urgency to pass urine, but I can't control it, and before I reach the hospital, before I reach the toilet, I tend to leak. This would be urge urinary incontinence. And there's one component where they have both. They have the urge component as well as the stress component. That's called mixed urinary incontinence. These are the three major things, major types that we come across. But beyond that, there are two other things that we look into it. So if you look at the patient's words, what sort of words they use, one is, doctor, when I leak when I cough, sneeze, or exercise, and urge, I cannot get to the toilet at the time. So that's two things we discussed. This functional and overflow is something where this simple sentence that I never feel empty and I constantly dribble urine is not doing justice to this condition. Overflow incontinence is something where I would put like a bucket of water where the water gets full, the bucket gets filled and then it leaks. So this is classical of overflow incontinence, where the patient goes into retention. Generally these patients are elderly patients or patients who has this urinary blockade, be it prostate or be it stricture or be it neurogenic problems for many months or years, where they are used to do this blockade. Then all that they feel is a vague discomfort in their abdomen. They don't have an acute pain which is very similar, which is seen commonly in stone block. They'll just say that I have some discomfort but I pass urine. Basically they'll be on diapers and they will wet the diapers. Every 20 minutes or 30 minutes they just leak 30 ml to 50 ml. So this is overflow urinary incontinence. This is one of the most dangerous type of incontinence, because practically they are obstructed and the back pressure changes will not allow the urine to produce more urine, and they allow acute kidney injury in these conditions. Functional urinary incontinence is a condition where if the patient is a geriatric patient, an elderly gentleman or a woman, where they have the urge to pass urine, they can control it, but before they reach the restroom, because of that physical limitations or physical ability, they will not be able to reach the toilet in time and they pass urine. This overflow incontinence and functional urinary incontinence are something that we just have to deal with it majorly with especially functional urinary incontinence with lifestyle modification, and the caretaker policy has to be changed. Overflow urinary incontinence has to be evaluated properly. So with this, we get into the first interaction, where we ask these 6 essential questions. 1, what triggers the leakage? That's the most important question that we'll ask when somebody comes to us with incontinence. Obviously, is it a cause leak or whether there's an overwhelming urge to go there. The second one is, what is the severity and the frequency? How often they have to go through this trouble, and what is the major thing that affects the quality of life? That's very important. What is the voiding pattern? Whether it is more common in the day or whether more common in the night. And obviously everywhere we have to ask about the point of urgency. If it's the urgency thing that's causing the trouble, or without urgency, when they cough and sneeze they leak. That's the voiding pattern. And the other important question that we all urologists and urogynecologists ask is, how are you emptying the bladder? Do you feel that you are emptying completely, or you feel that you are blocked? Is there a sense of incomplete emptying? This is usually associated with long-standing trouble. They do not complain of pain or major discomfort, but they just say that, doctor, I feel that there is always something inside. I'm not able to completely empty it. So that's the bladder emptying question. And obviously associated symptoms, whether they have burning, micturition. UTI can obviously cause repeated frequency and urgency, and sometimes a leak. And if they have hematuria, or if they have signs and symptoms of urinary tract infection, then that has to be evaluated thoroughly. And last but not the least, relevant medical conditions has to be assessed, be it an obstetric condition or a gynecological condition. If it is an elderly gentleman, we have to always look into whether he's got an obstructed prostate, whether they are suffering from neurological issues or chronic debilitating conditions, and diabetes. And if they have any symptoms of spinal cord compressions, I'm just telling about even something which is very common, like severe disc bulge, which is not obviously giving them trouble, but giving them difficulty with the voiding. Excuse me. Sorry? Okay. So once these basic evaluations, the examinations are done, then we have to think about the medication that patient may be on. So if the patient is having any form of incontinence or be it urinary issues, we'll always have to ask about the intake of diuretics, because we all know that it increases urinary production, and probably the patient feels too full too often, and then they have to go to empty the bladder. And the most common bladder irritants, that's coffee, alcohol, these are two common things. And whether the patient is on nighttime sedatives for their sleep, because these people generally these people will not have nocturia. They classically say that I take tablets, I sleep really well, I don't have this issue. But when they wake up in the morning, they will have this weird bladder fullness. They will not be able to empty early in the morning. It's classically called as hesitancy. They will just go stand there for 5 to 10 minutes. They will not be able to empty it normally. That is with regards to the sedatives and anticholinergics. So anticholinergics, be it in any form, it can impair the bladder contractility. So these people will have difficulty in passing urine, so they can go into retention, and this overflow incontinence is very common in these people. And then cholinesterase inhibitors can worsen urge incontinence. And alpha blockers, I'm not very convinced about this point, but still I would want to put it, because alpha blocker can relax the bladder neck, but the sphincter complex is a skeletal muscle. Alpha blockers generally do not act on the sphincter complex, the sphincter per se, but as the whole sphincter complex, some patients, especially women, they may have a little bit of stress urinary incontinence. But it's not something to be really worried about, but still this point has to be kept in mind. And AC inhibitors, as a physicians, you know it much better. It can cause cough, and it can worsen stress urinary incontinence. These are the most common medications or things that can kind of mess with the patient's urinary functions. So once the patient's there, we asked all these questions, we checked the review, and then basic evaluation would be a general assessment of how obese they are, how is the mobility, what is the cognitive ability of the patient. And then when we look at a patient who's got incontinence, always we look for a palpable bladder. Is the patient having a full bladder and leaking, just like an overflow incontinence, or she's just leaking because, or she or he is leaking because of urge or stress urinary incontinence. So the abdominal examination is very important. It also points to any other intra-abdominal pathologies. Pelvic examination for women and digital rectal examination for men is a very, very important thing here, because a man can have an enlarged, very hard prostate, or he may have chronic constipation with a severe fecal impaction, which will also block the urine pathway. So with respect to pelvic examination for women, we have to look for pelvic organ prolapse, be it uterocele or rectocele. We just have to see whether any prolapse is there, because this prolapse will mess with the angulation of the bladder and the urethra. This will worsen the stress urinary incontinence. And this is cough stress test. Generally, when we do a physical examination on a woman and we see when she coughs, she's spurting urine out, that is a gold standard sign that she's got stress urinary incontinence. Now the point here is, we have to understand that many women may have mixed urinary incontinence, where they may have stress urinary incontinence but an underlying urge urinary incontinence also. So before we get into proper treatment option, we have to rule out whether she is having a combination of these both incontinences. And neurological, simple gait and perineal sensation would check the integrity of the nerve roots that we really bother about with respect to urinary incontinence as well as the fecal continence mechanism. And the primary investigations, so we've asked the questions that we wanted to ask. We examined the patient, we checked their drug reviews, and then what investigations first we can ask as the primary physicians when a patient comes with urinary incontinence. So that's going to be urine routine and urine culture. If we think the patient is having a urinary tract infection, these two would point out to it. And we have to have a baseline assessment of what is the current renal functions. Obviously, your blood sugars and HbA1c, how much they are retaining. So that can be done in two ways. One, if we do not have an ultrasound, if the patient is accepting for procedure, what we can do is we can ask the patient to pass the urine in the commode in the clinic, and we can insert a small feeding tube or a small sized catheter to check how much urine is still remaining. We don't need a fancy uroflow, we don't need a ultrasound for it. We can check that. But if the patient is a bit uncomfortable with it, obviously the best thing is ultrasound of the bladder to look for post-void residue. And avoiding dairy is something which is very, very useful when we refer the patient to urologist or urogynecologist, because it will give a snapshot of what the patient is going through. So generally avoiding dairy is it's a clinical sheet where they enter how much and what sort of drinks they take, be it tea, coffee or water, and what is the amount and what is the time duration that they take, and how often they use the restroom. And it is generally asked for 3 days before the start of any treatment, and then every visit we ask them to come up with a 3-day bladder diary, so that we can compare what was before and what medication had an effect, and what is the current status. So what she takes and how often she passes urine, and if they are leaking, then we have to add how many episodes of leak and what caused the leak. It is just for 3 days. We can tell them, okay, Friday, Saturday, Sunday, please do it for me and come and see me after a couple of days. We could just request them. Most of the patients oblige. Surprisingly, most of the patients oblige. And if there is a leak, then we can ask how many pads are you using. If they are using an adult diaper, then we can ask, okay, fine, you can just come up with the number of pads. So these are the details which will be invaluable when we treat the patient. And obviously renal ultrasound would be better to look for any anatomical abnormality that we're looking at. These are the primary investigations we are going to ask when a patient is going to come up with such complaints. Now, there is this universal first line management, be it stress urinary incontinence or urge urinary incontinence or mixed incontinence. Then we have to look at a set of things. So that is, first and foremost, as their primary physician, we have to explain what they may go through. Most of the women, it takes lots and lots of courage to come up to a doctor and then tell doctor, I'm leaking. It's very embarrassing to anybody. So when they come up, first thing we say is, okay, don't worry, we are there. And this is very common in Indian women or any women of any age. So we will look into it. That's the first thing. And if the patient is a bit on the healthy side, then we tell them, okay, would you consider going for a diet or exercise, basically weight loss. And most of these patients, especially somebody with overflow incontinence, they may have also, or somebody with pelvic floor dysfunction may also have associated constipation. That is something that we have to ask, and if needed, we have to correct it very promptly. And the lifestyle modifications, the coffee and tea, most of the time, if there's a young men or women, so what I generally say is, that's my understanding is, when they're working in IT or any stressful job, they get up from their work desk to go to have a tea or coffee, basically because they wanted a break from the work. And most of them do not care whether when they go out for the break with the friends, whether they take tea or coffee. Even if they take milk or Boost, Horlicks, they're okay with it. They just want to get out. So we just tell them that why can't we just cut this down and see. So this is universal lesson. Any type of urinary incontinence, we are going to do it. And obviously the fluid timing. So this is more common when a patient is having nighttime difficulty with incontinence. We tell them to take early dinner, finish all their tablets by 7:30, 8 o'clock, pass urine at least 2 or 3 times, at least a couple of times before they go to sleep, and then they can go. So this fluid timing with respect to even the bladder diary, as well as what is avoiding timing, this modulation will help them a much better thing. Obviously bladder diary we discussed, and this is one of the least common or the most commonly misused physiotherapy. We all tell them we have to do pelvic floor muscle training, PFMT, but it's very difficult to assess whether the patient is following what we are trying to tell. If I'm going to have this finger and then tell them, okay, fold your thumb, she can do it and we can see it. Fold your little finger, we can see it. But if we tell them, okay, you tighten your pelvic floor, which she also doesn't know what is it, and we also can't see what she's doing. So this is one area where we tell, we share YouTube videos, we tell, okay, go see the physiotherapist, or tell our physiotherapist or our technicians to help them. But most of the time we tend to fail in assessing whether they have understood it or whether they're doing it properly. So that place has to be given more importance. Pelvic floor muscle training is of utmost importance for any form of urinary incontinence, and we have to give an ample time for it. 3 to 6 months of a well trained, well properly coordinated pelvic floor muscle training has to be done. And obviously we go and review the medicines as well as comorbid conditions. This is for everything. And now coming to the most common type, that is stress urinary incontinence. The first line management is obviously the conservative thing, where we go for weight reduction, PFMT for at least 3 months, provided somebody is overseeing it. It is a bit difficult. So we have pelvic floor muscle training teams in various cities, physiotherapists who are dedicated for pelvic floor physiotherapy, where they use biofeedback. In the sense, they use just, it's not as effective as the ECG electrodes, but they use some electrodes, skin electrodes placed that in the perineum near the vagina and the anal, the external anal thing, and they record it. They tell them, okay, now you compress it, you relax it. It is not very, very specific, but that is the best thing that we can get. The next best thing is having a needle electrode, which is very uncomfortable for the patient. So pelvic floor physiotherapy with biofeedback is something that we should all start suggesting our patients. And the other one is we have to look into if the patient is coughing, just look into the other problems, coughing, constipation. We make sure that we try and reduce any sudden increase in abdominal pressure. And this vaginal estrogen supplement is just to increase the tissue coaptation. You know, in the continence mechanism, beyond the bladder neck and the sphincter complex, the urethral mucosa coapts, it just closes, and it has got a certain percentage of its importance in the continence mechanism. So after post-menopause, the dryness and shrinkage of these things will also have an effect. So for what it was worth, that vaginal estrogen can also be used for these patients. And pessaries, I'm not an expert on it, a urogynecologist would be the best, and I have not used pessary. If such conditions come, I refer my patients to urologist or gynecologist or urogynecologist. So this is the first line management of stress urinary incontinence. Now, if we understand that we have a proper diagnosis with stress urinary incontinence, we given all the medicines and all the pelvic floor training, and we have made sure that they are okay. I mean, they're following everything, still they leak. Then comes the surgical management. It is done by the urogynecologist as well as the urologist. So there are things that we look in. First is the mid-urethral slings. And there are 3 things that you look into: mid-urethral sling, Bursch, colpo suspension, autologous facial slings. That is first one. Let me just get into the details very briefly into these things. Then bulking agents, and last but not the least, artificial sphincters, be it for males or for women. We can use these, we can just go step by step. Now coming to this urethral slings, I just have a small video which probably will give a better idea. So this trans-obturator tape, this is commonly called as TOT, trans-obturator tape. There's also trans-vaginal tape. This animation has been borrowed from a lot of websites and YouTube's give credit where it is due. Here, what happens is that they make a small incision on the groin, and a tape is introduced from. There are a lot of ways to do it, but this is one common way where they introduce a tape through the perivaginal tissues, on both the sides. We just keep it like a hammock. நம்ம பீச்சில் வந்து ரெண்டு தென்னை மரத்து நடுவில் கட்டுற மாதிரி ஒரு ஹேமக் மாதிரி it just lifts it up, so it maintains the angulation over there. So across the globe there is, especially in the developing countries, they don't want plastic inside their body, so such kind of people can go for autologous slings where the rectus sheath is taken 10 centimeter by 2 centimeter, and then it is used as a thing. And burst colpo suspension, it's out of vogue now because it is an intra-abdominal surgery where they use sutures to lift up the vaginal vault, but it is not used now because mid-urethral slings are much better. And for mild cases we can use urethral bulking agents where we put a camera through the urine pathway and just inject bulking agents. These are nothing but cross-linked polyacrylamides where we put on all the sides so that the urethra, especially urethral mucosa, coapts so that they don't leak much. So these are the common things that we can use, but if nothing is working or if the patient has got some severe neurological difficulty, this is a male model. This is a common model called, this device is called AMS 800, Boston Scientific, where they, so I can't see the thing. So the cuff is put across the bulbar urethra and there is a pump and which activates. When they put it and activate the pump, for 2 minutes the sphincter relaxes where the patient can void, and after that, after 2 minutes automatically it restores the pressure. So this is what it is. Now that's for the stress urinary incontinence. Urge urinary incontinence is basically a medical management where we do all the primary things that we spoke about, and then we go for we go for all this physiotherapy, urgency suppression techniques, reducing bladder irritants and all this. And coming to the medication, so these are the common medications that we use. Antimuscarinics, sulfasalazine and tolterodine is most commonly used in adults, and oxybutynin in pediatric patients, and trospium. Trospium is a quaternary amine. It has very little blood-brain barrier crossing, so that they do not have the cognitive difficulties. So and the other one most commonly used is mirabegron. Vebegron is better than mirabegron, but it is not introduced in India yet. And obviously vaginal estrogen. So these are the basic things that we treat for urge incontinence. But if the patient, again, if the patient is not responding despite of lifestyle modifications and medications, then there are the other couple of things that we can do. Tibial nerve stimulation, intravesical botulinum. So botulinum toxin, we all know that Botox is used for all this dermatological condition as well as when muscle spasm. It can also be used for overactive bladder. There's a very small video for that. So intravesical Botox injection where we take Botox and we give 100 units of Botox in 20 different places. So what it does is it kind of reduces the overactivity of the patient. So Botox, as we all know, the effect lasts from 6 months to 18 months, the average being 9 months. So now here, if the patient, we split 5 on the lateral wall right, 5 on the lateral wall on the right, 5 on the posterior wall, 5 on the dome. This is what we give, and generally the outcomes are good, but also depends on the severity. If the medicines are not working, we can keep it as an additive. But we also have to understand that if the patient goes for hypotonicity, then that will also recover in 8 to 9 months.
Release. Dysfunction of the sensory and motor pathways alters the checks and...
So that is sacral neuromodulation. So sacral neuromodulation is basically a device where we keep a thin lead in the S2, S3, S4 foramen, which it modulates. To put it in a very simple perspective, it's like the fan's regulator. If you want the fan to run a bit fast, you can just keep it a bit faster, and if you want to reduce the speed, you can reduce it. So sacral neuromodulation modulates the signal from the bladder to the spinal cord and the brain, and in such way it reduces the overactive signals. It works wonderfully for OAB in neurogenic elements, especially multiple sclerosis and Parkinson's and all this, which is not responding to conventional medicines. And when it when it comes to mixed urinary incontinence, we have to clearly sit and speak with the patient which bothers you the most, whether it is the cough and the leak part, or whether you have to rush to the restroom but you still leak this part. So we have to see, and then we have to treat which bothers the patient most. All right, so right, this I'll finish with this slide, just 2 minutes. When this is one of my favorite slides. What is the urodynamics? When a lot of general practitioners, gynecologists, and other specialists ask, why do you need a urodynamics? So you have an ultrasound. I've done an ultrasound. I know what is the prostate size. I have a CT. I have an MRI. I have all these things. So why I need a ultrasound? So urodynamics. So this is the thing I always tell. Let me tell a story. In this situation, it is 2 stories. So this is one sumo wrestler. If I ask a question to the honored members, so they will say who is going to win. Obviously, the fat guy is going to win. But if I ask these 2 people to play a game of chess, who is going to win? So that is anybody's game. The kid can win, he can win. Likewise, this is the first part. So we don't know what is the functional ability. We know what is the physical ability. We don't know what is the functional ability. Let's say there's a bladder, there's a prostate. Whether the bladder is compressing as it's supposed to be, we don't know. So that is first. The second one is, let's imagine we are sitting in a village and we are sitting, suddenly the water stops. So the first common thing that we'll go and do is, we go to the motor room to see whether there is electricity or whether the motor is functioning properly. And if it is functioning properly, we'll go back to the pipes and check whether the water is flowing unblocked. That's the same thing that we do. When the urine stops, we have to go back and see whether the bladder is functioning properly. If the bladder is functioning properly, we have to see whether the sphincter and the urethra are functioning okay. So this is one thing that will give you numerous data for treating whether it is urge urinary incontinence, overactive bladder, underactive bladder, she's leaking because of the urge component, whether she's leaking because she's full, she's not able to compress. All the details will be here. So, so with respect to the investigations, when we have a stress urinary incontinence, urge urinary incontinence, mixed urinary incontinence, we kind of do the lifestyle modification and approach them with the proper medicines, and if it's not working, these are the surgical options that we can choose. Thank you so much for the opportunity. I hope that it was useful for everybody. Thank you so much, sir.
Thank you, sir. Thank you.
I'm sorry, sir. I didn't know that it would go this long.
Yeah, it was very useful for the audience.
Thank you. Thank you.
It was very exhaustive session, as you mentioned.
I understand.
It started with the symptoms and how to approach the patient, and then how to treat.
Yes, sir.
The main thing, one of the message which we believe for the general public whom we treat, 5 C's we tell: the decrease carbonated beverages, decrease caffeine, decrease cortisol, stress you mentioned, 74%.
Yeah, that is very vast, sir. I couldn't touch on everything.
Decrease cortisol, decrease caffeine,
yes,
and decrease calorie, especially for overweight.
Oh,
so calorie intake. We tell that 5 C's will be taught regarding the urinary incontinence. Question and session we will discuss after the other speaker ends.
Sure, sir.
So it was a wonderful presentation, sir.
Thank you, sir. Thank you, sir.
So our next topic is going to be on abdominal pain. So the session itself is very interesting. First we started with anaphylaxis. All these 3 topics are which we commonly see in clinic, but we will not be able to approach properly. So that's what we are discussing. So now we'll introduce the speaker, Dr. Vishnu, Abishek, Raju, cardiologist, senior consultant, gastroenterologist. Sir is from Apollo Grims, and Sir has completed his MD Internal Medicine in Salem, Kasturibai Medical College. Anyway, it is being displayed. And again, Sir is going to speak on a very interesting topic which we see day to day in clinical practice. Sir is going to discuss on abdominal pain. So where we have differential diagnosis. So the main thing is we have to be knowing which abdominal pain we are going to treat. That is very, very interesting. I think that Sir will be alluding on the differential diagnosis of abdominal pain and how to approach the acute as well as chronic abdominal pain. Back to you, sir. The medical gastroenterologist, sir.
Thank the organizers for the opportunity. Let me see, we can talk about only the approach. I'm supposed to finish off in a short time. So let's keep it more practical, and if and when anybody has any interesting doubt or anything about the newer things, you can always interrupt me. I'll try to keep it very clinical and simple. So this is the overview. If there is an unstable patient, there is no time for evaluating. Do a point of care emergency ultrasound and treat. Otherwise, if the patient has all the stability, then go for history, physicals, radiological diagnosis, labs, and then comes the clinical acumen to properly diagnose an abdominal pain case. History, you can organize the type of pain based on location, whether it is acute or chronic, and the type of pain. If a pain is very sudden, say the patient comes to you, very sudden onset pain, it is most often coming in these three categories. Either it is vascular insufficiency, a vessel is blocked or something, or a vessel has ruptured, or there is an obstruction or perforation, either obstruction of a viscus or a perforation of viscus. All these things present very suddenly. Subacute can be either an infection or an inflammation. A slow TB abdomen, an inflammatory bowel disease can present with a very smoldering subacute pain. A chronic thing can actually be a cancer, a tumor, or again a vascular insufficiency, chronic mesenteric ischemia. And again, functional pain can also be going on for months together. This is how we can characterize a pain. As I was saying, when the patient is writhing in pain, very severe pain, they may not give you any history. So when the patient is in severe pain, the approach is always give the painkiller first, make the patient pain free, only then we can proceed at all. So that was the first slide. Sorry. So as I said, unstable patient, always do the point of care ultrasound as an emergency. Then a stable patient, do the rest. Location, acute versus chronic, and type of pain. If it is sudden, vascular, obstruction or perforation. Chronic means either infection, inflammation or tumor, and it can also be functional pain. And any subacute pain is usually kind of infection or inflammation. So when we talk about pain, divide the abdomen into 9 quadrants, we say. Basically all the pain when the patient present to you, it's either in the 4 quadrants, and when they tell the pain, it's either in the epigastrium, around the umbilicus or hypogastrium. Now why this epigastric pain around the umbilicus or hypogastric is important is almost all the pain will localize in either one of these things based on the visceral origin. No visceral pain will exactly come on the point. For example, a gallbladder pain is not going to present to you in the right upper quadrant all the time. Likewise, an appendicitis pain is also not going to present to you in the right lower quadrant all the time. A peptic ulcer not in the left upper quadrant all the time. It is based on the visceral supply. So, epigastric pain will be arising from any of the organs arising from the foregut. A periumbilical pain will be from any of the organs arising from the midgut, and hypogastric pain, a suprapubic pain, will be any of the organs arising from the hindgut. If you know what are the organs arising from the foregut, midgut or hindgut, based on the sympathetic nerve supply, we can tell the origin of pain. Look at that diagram. A foregut, say liver, gallbladder, pancreas, stomach, spleen, everything arises from the foregut. It is supplied by greatest splanchnic nerve T5 to T9. So obviously any inflammation which is arising from these viscera, the visceral pain will be felt in the epigastrium. If small bowel below the level of ampulla of Vater, jejunum, ileum, appendix, cecum, ascending colon, right 1/3 of transverse colon, these are all midgut. Any of these visceral pain will be felt around the umbilical region, not exactly here and there localizing. Beyond the transverse colon, everything is in the hindgut. Now, when the visceral pain has its pathology spreading around, coming to the serosa, touching the parietal peritoneum, that's when you can localize the pain. So that's why an appendix which is felt in the umbilical region, the pain felt in the umbilical region, as the appendix inflames, touches the parietal peritoneum, that's when the pain shifts from the periumbilical region to the right lower quadrant. So never get confused about the organ of origin. And a transverse colon pain is not going to present in the epigastrium, it is going to only be presenting in the hypogastric region. So a sympathetic supply of the hindgut is T11 to L2 nerve. So wherever that nerve is supplying, there only you can feel the pain. And what about the vagus nerve or the parasympathetic? Parasympathetics are not the pain nerves, parasympathetics are the reaction nerves. When the patient has pain, the vagus nerve reacts in the form of tachycardia, sweating, BP, low drop in the BP, rise in the BP and all those stuff. Now, based on the quadrant of pain, 9 quadrant, you can put various pathologies on that. An epigastric pain can be a peptic ulcer disease or pancreatitis, which is the most common. A right upper quadrant pain which is progressive can be cholecystitis, can be gallstone cholangitis and all those things. A left upper quadrant usually is a splenic injury or a pyelonephritis and stuff. A periumbilical pain can be anything, especially abdominal aorta aneurysm is very, very important, and gastroenteritis or a perforation of viscus is very important. And a kidney pain usually comes in the flanks. A right lower quadrant pain can be typhlitis or appendicitis or ovarian torsion, and a left lower quadrant can again be a ovarian torsion. Any hypogastric pain can be a fibroid pain or a uterine pathology. Now, are these the only organs? Based on this, can we just say that, okay, this pain is coming from this organ? Unfortunately, we cannot do that because we have referral of pain. For example, a peptic ulcer pain or a pancreatitis pain can be felt in the periumbilical region or either of the flanks again. That is the confusing part. An appendicitis pain usually is felt in the periumbilical and goes to a right iliac fossa. Any pelvic pain, for example a torsion, a fibroid, all those things can be felt on either side of the flanks, right iliac fossa or left iliac fossa. And a diverticulitis, if you feel like a sigmoid diverticulitis is there in the left iliac fossa, that's where sigmoid colon is there, we may be wrong because the pain may actually be felt very much top on the left upper quadrant. That sometimes confuses us. So we should be aware of where the pain can get referred. Example, a cardiac pain can be, or say an MI or a pneumonia can be referred to the epigastrium, right? Likewise, we have a lot of patients with peptic ulcer disease and esophagitis having arm pain, jaw pain and shoulder pain. And gallbladder pain can be the scapula and shoulder. An acute abdomen is usually a couple of weeks pain. It is usually days or hours old, and we should not forget about a chronically persisting pain suddenly having acute exacerbation. So there can actually be a malignancy or something sitting which can present to us with an acute exacerbation. Immediate medical attention is required to differentiate between surgical or non-surgical. Our job sitting in the clinic or an outpatient department or an emergency triage room is to say whether that patient requires an emergency surgery or can be managed conservatively and whether we can keep on going for evaluation. These are the possible causes of sudden onset severe abdominal pain one should never forget. Aortic dissection, high mortality, every hour the mortality exponentially increases, we should never miss. Intra-abdominal hemorrhage, whenever the patient has intra-abdominal hemorrhage and you ask the patient to take a deep breath, there will be a shoulder pain, okay? And ischemia of a hollow organ, acute mesenteric ischemia, that is again a medical emergency. Obstruction of either of the viscus, either a hollow viscus like a ureter or a bile duct, again is an emergency. Perforation of hollow viscus, they also present very sudden. Rupture of an aorta. So all these things coming under three categories: obstruction, perforation, vascular problem. These three things are the causes of sudden onset abdominal pain, which always requires emergency medical attention, we should never miss. A chronic abdominal pain smolders over years and months. It's not life-threatening. Outpatient workup can be slowly done based on the localization and characterization. So what is the difference between a visceral pain and a parietal pain? We all know that when the pain is very vague, no? When the patient is not able to exactly tell, and that's usually visceral pain. What causes a visceral pain? Visceral pain originates from the inside of the gut. Either the mucosa or the visceral peritoneum is inflamed. The parietal peritoneum or the fat area is not inflamed. And usually the nerve fibers which carry the pains are the unmyelinated C type of fibers. So localization is very, very, very poor. The patient will not be able to tell. It's a vague pain, diffuse and dull pain. The sensation is also somewhat dull aching. It won't be sharp stabbing or something. And the triggers are generally some inflammation, say for example peptic ulcer disease, gastritis, patient is taking some drugs, chemical induced. Those are the usual triggers. And patient's behavior is also somewhat restless. They won't be able to tell you what it is, so they'll keep on getting up and down, sitting, standing and all those things. So they'll keep on be writhing in the pain. They won't be able to localize. Whereas shift to parietal pain, the somatic pain, the nerves which are carrying the pains are myelinated A-type, delta-type fibers. The patient will be absolutely still because any movement, any type of movement will exactly trigger the pain. Peritonitis, it will trigger because the parietal peritoneum is being inflamed. That is the origin. The abdominal lining is being touched upon. So that's when the patient lies still. The sensation also very sharp, stabbing. The patient will be exactly able to give you the finger pointing sign. This is where the pain is. So that's how the trigger is always an infection, inflammation, tumor or irritation, whatever it is. And the patient's behavior is also lying still. And the character of based on the character we can tell where the pain is. If the patient is lying still, peritonitis. If the patient is writhing, it can either be a biliary colic, intestinal obstruction or a renal colic. Whenever the patient takes a fatty meal, a biryani and all those things, puffs and all those things and comes and tell you after 2 hours I am having severe pain, it could be a biliary colic. Eating actually relieves the pain in duodenal ulcer. Remember, when there is a patient having duodenal ulcer, eating actually kind of shuts the area between stomach and the duodenum. So the ulcer is not irritated by any sort of acid. So there is a temporary pain relief for 2 hours. Eating worsens the pain in multiple reasons. Gastric ulcer, mesenteric ischemia, pancreatitis and all those things. So that's what we call the cytophobia, fear of seeing the food at all. It's called cytophobia. Examination wise, if the patient has a rigid abdomen, guarding and all those things, immediately go for a point of care ultrasound, no waste of time. If required, an ultrasound is not very good, go for emergency CT. If the vitals are unstable, again call in the surgeon immediately. If the vitals are stable, patient has no tachycardia, the patient is not having severe pain, sit and take a proper history and examine. Whether you want to know the patient's abdominal pain is from the abdomen wall or from inside, the important sign is Carnot sign. Okay, ask the patient to lift the head up. If the abdomen wall tightens and then you press the abdomen, if the pain still persists or worsens, it means the pathology is arising outside the abdominal organs, it's from the abdominal wall. If that is positive Carnot sign. If the Carnot sign is negative, like the patient tightens the abdomen and the pain goes away on your probing, it means the origin of pain is inside the abdominal wall. The abdominal wall is protecting the organs. Okay, that's Carnot sign. For example, in this clinical study, a patient presents to you with an acute abdomen pain around the umbilicus, then it goes to the right iliac fossa, the patient is sweating a lot. On examination, the patient has got tachycardia, fever, and rebound tenderness and all those things. Then you go and see what are the signs, other signs you are seeing. McBurney's tenderness positive, rousing sign positive, obturator signs positive, psoas sign positive. Then you go and do the lab, suspecting acute appendicitis and having some other DDs in mind all the time, always having some DDs in mind like Meckel's diverticulitis, cecal diverticulitis, kidney stones, ovarian torsion and all those things. Then you go and keep the patient in NBM, start IV fluids, give painkillers, send it for imaging either CT or ultrasound, you clinch the diagnosis. But always whether to go through that pathway, everything depends on your history and physical examination. That will never be gone. So this is McBurney's point. From the anterior superior iliac spine, right 1/3, medial 2/3. That area if we press, that is McBurney's tenderness. Most common signs seen in acute appendicitis. What other signs are seen? Always clinical exam should never be forgotten. This is rousing sign. See, left iliac fossa you keep the pressure and appendix gets the pain. Why? The transmission of the gas into the colonic contents transmits the pressure to the appendix, pain arises. So left iliac fossa pressure, pain is elicited in the right iliac fossa. That is rousing sign. Anything else you can say? Obturator sign. Flex the right leg, internally rotate the knee and put the leg outwards. Obturator muscle is stretched. A retrocecal appendix will be, an inflamed retrocecal appendix will be irritated and pain will be worsening in obturator sign. In psoas sign, put the patient in left lateral, flex, hyperextend the hips like this. That will extend the psoas and it will compress upon the inflamed retrocecal appendix, pain will be worsening. In a patient where you don't have abdominal signs, McBurney's point tenderness is not there, still you feel appendicitis because of retrocecal appendicitis, you do those two signs like obturator or psoas, you will be able to pick up an appendicitis. What is Dunphy's sign? Ask the patient to cough. While coughing, if the patient feels a pain in the right iliac fossa, again acute appendicitis. This is Aaron's sign. Press on right iliac fossa, feel the pain on the epigastric region, then again it's an acute appendicitis. It's called an Aaron's sign. It's usually seen in chronic appendicitis. Okay, and this is Bloomberg's sign. Bloomberg's sign is seen in so many conditions, not only appendicitis. Like if you tap on the patient's abdomen or give a firm compression and take your hands off, release. That's called rebound tenderness. What does that tell us? It means there is an inflamed viscous, an inflamed viscera which is touching the parietal peritoneum. We are compressing the visceral organ and releasing the parietal peritoneum. The disturbance on the parietal peritoneum gives a sharp pain. That is rebound tenderness. It can be seen in pancreatitis also. It can be seen in appendix, ovarian torsion, anywhere. It means that's a significant pathology. Whenever there is a rebound tenderness, patient has got a severe problem lying inside the abdomen. Do not ignore. Do an imaging, either ultrasound or a CT. This is cholecystitis sign. This is how originally Murphy's described it. This is the exact picture. Patient is asked to sit. Murphy stood behind the patient, hooked the fingers below the right costal margin, asked the patient to take a deep breath. If the patient is not able to take a deep breath, if there is a catch in the breath, that means there is an inflamed gallbladder which is hitting the finger. That is typical for cholecystitis. Now remember, in spite of a negative Murphy sign, a cholecystitis can still not be ruled out. It's always requiring imaging and further clinical signs. Okay, this sign around an ecchymotic patch around the umbilicus is called Cullen's sign, and around the flanks it's called Gray Turner sign. Where do you see this? You see this Cullen's sign and Gray Turner sign if there is an intraperitoneal visceral hemorrhage or a retroperitoneal hemorrhage, most commonly seen in a severe acute pancreatitis. Of course, there are other areas also where you can see like a trauma, ruptured ectopic pregnancy, ruptured abdominal aorta aneurysm and all those things. Now, if you see a Cullen's sign and a Gray Turner sign because of hemorrhage, look for other signs also which can happen in pancreatitis. Say, for example, there is always a visceral fat inflammation in pancreatitis. Okay, visceral paniculitis we call. So you can get all the pancreatic paniculitis on the arms. You can have this Fox sign in the inguinal ligament, and the scrotum, everything can go for ecchymosis called Bryant's sign. So these are the other signs which you can see in pancreatitis. So based on the examination, you are given one choice. Now you go to the emergency room, and the ER guys will ask you, doctor, which test do you want? You want an ultrasound or you want a CT abdomen? Emergency point of care ultrasound abdomen, where you think is a focused pathology, you can still ask for it, because an ultrasound abdomen gives you a very quick diagnosis, and if there are no cholecystitis or appendicitis, you can actually send the patient home. It has been shown to be very, very useful. But if the ultrasound machine is not good and if you don't trust it, then you can shift to a CT abdomen, probably a contrast CT abdomen all the time. Ask the patient to get an ABG done. ABG value itself will give you a creatinine value. If the creatinine is normal, always getting a contrast CT abdomen gives much more added value than giving a plain CT abdomen. If you suspect a viscous perforation or an obstruction, do not give oral contrast. Always keep the patient NBM if there is a suspicion of even mesenteric ischemia perforation, because we do not know when the patient is going to go for surgery. Also, anything intake, anything which is put in the mouth can actually worsen the pathology. So always keep an patient NBM. These are X-ray signs. Many a times we are reliant on X-ray abdomen which is ordered in a clinic. We always do not send the patient for ultrasound. We always have a next door to some X-ray will be available. So always it's better to know some X-ray signs, named signs, so that you can diagnose all these emergencies very easily. The first thing is Wriggler sign. I don't have a pointer. Okay. Yeah, this is a Wriggler sign. Generally, you see gas shadows inside the bowel, correct? If you see gas shadows on either side of the bowel, outlining the bowel wall, that's called a Wriggler sign. Where do you see it? It's case of perforation. This is pneumoperitoneum, an X-ray abdomen taken in a supine view. That's called a Wriggler sign. Now here, that's called a thumb imprint sign. It's like almost like a kainata madri. Some thumb is taken and it's kept on that bowel wall. This is seen in ischemia. This is seen in bowel ischemia. This is a sigmoid volvulus, bent inner tube sign, or a coffee bean appearance. When you have a patient with severe abdominal pain who has not passed stools, you order an X-ray abdomen, you see such a huge dilated colonic thing which is bent like this, like a coffee bean. That is a sigmoid volvulus. This again, it's an emergency, but it can be dealt with immediately by just doing a PR or putting a deflatus tube, or inserting a sigmoidoscopy, and decompression also can immediately relieve the pain. What is this sign? When you saw the Wriggler sign, it is X-ray abdomen supine view. This is X-ray abdomen erect view. This is showing a crescent sign, air under the diaphragm, bilaterally. So that's a pneumoperitoneum, perforation of a viscus. Now this is perforation of a viscus, like say duodenum, ileum and all those things. Jejunum, ileum, all those things. What if there is a duodenal perforation? Will a duodenal perforation present like this? No. Duodenum is a retroperitoneal organ, the second part. So where you can see the air shadows will be seen around the kidneys. If you see a kidney outline in an X-ray abdomen, that means that's a retroperitoneal perforation, duodenal perforation. What is this sign? This is, you can see the large bowel shadow. This is small bowel, small bowel. What is the difference between small bowel and large bowel? A large bowel will have a hostile folds like this, picket fence appearance. A small bowel, the valvulae convolutus are stacked like this, stacked coin appearance. So in this one, this is the stacked coin appearance, whereas this is a picket fence appearance. This shadow is a large bowel, this underneath is a small bowel. And you can see that the large bowel is cut off. That is called colon cut off sign, most commonly seen in acute pancreatitis. It can also be seen in diverticulitis also. Why? Because the colon is not allowing any further peristaltic movement beyond this point. The gases has stopped there. That's an acute stop in the peristalsis. That's usually seen in pancreatitis. Now what is this sign? You can see multiple air fluid levels, correct? Whenever we see multiple air fluid levels, immediately in an erect X-ray abdomen, we say it's an obstruction. What I want you to notice, in case if this multiple air fluids levels are not seen, you have to concentrate on this small things. Can you see the small things? Small. That's called string of beads appearance, or a pearl necklace madri irko. String of bead appearance is also small bowel obstruction. Any small bowel obstruction, you know what to do? Call the surgeon, right? Ultrasound abdomen. We don't have to learn ultrasound abdomen all the time, but in case, God forbid, we need to diagnose at least two conditions, an acute appendicitis, a cholecystitis. An appendix is like this, a tubular organ with a muscle around. and the fat is all inflamed. Any fat, when we call inflamed, what do you call inflammation as? A white layer is a fat, and when it is hyperechogenic, it's called fat standing and inflammation. And that is the appendicular lumen. This is ceca. This is a gallbladder. Okay, you see this structure light beyond which no shadows are passing through. An ultrasound passes the shadows. It touches this area beyond which it's all black. This is called acoustic shadow, and it is cast by a stone. A gallbladder has a stone, and there is pericolic collection. If you measure this wall thickness, it will be more than 4 mm. That's a classical case of acute cholecystitis. Even if you don't know, somebody comes and produces an ultrasound abdomen, reports to you, sir, gallbladder stone, whether we should operate or not. See whether cholecystitis is there or not. Whether there is pericolic inflammation and collection, no means no. Don't send the patient rushing for surgery, always get a second opinion. And what are the labs? Once we identified all this imaging, we still have not identified what the diagnosis is. Probably are going to send it for either a triple phase contrast CT abdomen with oral contrast and rectal contrast, or an MRI abdomen. Beyond which, that's all like which is better, MRI is better, CT is better. Actually speaking, it depends on the center where you are practicing. If your radiologist is not trained in MRI, he will do a complementary CT along with an MRI also. I think many of you have undergone that. You will send it for an MRI abdomen, they will do a complementary CT just because they are not able to exactly tell what the pathology is in the MRI. But MRI abdomen is actually good. And these are the labs. Why should we do all CBC, PCV? In an abdominal pain because of dehydration, if the hematocrit goes up, the pain worsens, it will lead to complications. Okay, that means it's a severe case. And if the C-reactive protein is elevated, it means there is inflammation. Amylase lipase, will you do both amylase lipase for an acute abdomen? Say the patient presents to you with 2 hours of pain, amylase or lipase? Amylase rises as early as 2 hours, peaks by 12 hours. Okay, whereas a lipase will rise by 12 hours, peaks by 3 days, and it comes down by 10 days. So if the patient is short of money, do amylase first. If the patient has come to you after 1 day of pain, do amylase and lipase both. Whereas if the patient comes very early, money is less, just do one test, means only amylase, because lipase will not go up in that condition. Also, one more specific thing is, amylase is more for gallstone, lipase is more for alcoholic pancreatitis. Lactate, why should we need lactate? In a case of mesenteric ischemia, the lactate goes up. Either you can get a venous lactate or an ABG. When you see this lactate level is very high, it means the patient is suffering from ischemia inside the body, very sick. Better admit the patient, keep the patient NBM, start IV fluids, call in the surgeon, and arrange for further higher imaging or either for emergency laparoscopy. Creatinine is very important always, because CKD patient suddenly can present to you with an acute abdomen because of exacerbation. So creatinine is the reason for doing that is that, not only because we have to do an imaging like a CT, that is one of the reasons. LFT, whenever there is an acute hepatic necrosis, say toxin, poison intake, anything, any further meter, can also present with acute abdomen. So always do an LFT as well. CKMB and troponin, why am I looking for cardiac markers? You will not believe, in my OP, many of the elderly patient coming with some sort of abdominal pain, the first thing I do is not ultrasound abdomen, please get a ECG, CKMB and troponin. First rule out an MI, acute coronary syndrome, only then evaluate for an abdomen, because heart takes the precedent, not the abdomen. And beta HCG in a young female coming to you, because why? It can be a ruptured ectopic pregnancy, so be careful. So these are the special considerations. Very young patient, no? How much time I have? 8 minutes. Okay. Very young patient, appendicitis or trauma and secondary to abuse, all those things they can present with pain. And pelvic inflammatory disease, Meckel's diverticulitis, cystitis, enteritis, IBD, these are all seen in very young patients. And when a woman presents with a chronic abdominal pain, never forget about endometriosis, because that's sort of a debilitating sort of illness. Very old can present. Say an elderly patient can actually come to your OP and sit and silently, but actually can be harboring a very severe problem like an obstruction or a perforation, because they will tell also less, the signs are also very less. You don't have such a great immune power in a very elderly patient to mount such an immune response so that they will be writhing in pain or some sort of serious signs will be there in the body. So always take them very seriously. Women, pregnancy test, beta HCG, pelvic exam, and point of care ultrasound, pelvic scan, all those things are essential. Why? A ruptured ectopic, ovarian torsion, pelvic inflammatory disease are all common. This is what you have to keep in mind for women. Elderly, as I told, the signs are less. Heart takes the precedence. Pneumonia and MI can present as abdominal pain. Aortic dissection to be ruled out. Now what about chronic abdominal pain? One thing which you want to know is a chronic mesenteric ischemia can present as a smoldering form of abdominal pain. A good quality, high perfusion, triple phase CT will pick up the ischemic findings like thumb imprinting sign, hypoperfusion, mesenteric fat standing, creepy mesentery and all those stuff. So high index of suspicion is important. When do you suspect these kind of mesenteric ischemia? Postprandial pain. Immediately after eating, up to 2 hours the patient will be feeling the pain. They'll have cytophobia. They won't feel like eating at all. The weight would have lost. There will be sometimes nausea and diarrhea also. The diagnosis depends on higher imaging, and treatment option depends on blood thinners, medications. Rarely we send the patient for angioplasty or reconstruction of vessels. What about metabolic causes of pain? Sickle cell, the last 2 slides. So you can, whoever is feeling sleepy can, last 2 slides. Metabolic causes of pain is sickle cell crisis, diabetic ketoacidosis and porphyrias can present to us with severe abdominal pain. I have seen very less cases of porphyria in my life. I don't see here much often, only 2-3 cases I have seen. And diabetic ketoacidosis presenting to us as pain is the most common cause of pain which we see in OP. Any elderly, high uncontrolled sugars, the ketone buildup will present with severe abdominal pain. Sickle cell crisis, every test you do, everything will be negative. And even the hemoglobin sometimes won't give you such a big clue. But the crisis is so severe, only on the 2nd or 3rd day we even pick up the case that it is a sickle cell crisis. So do not miss it. Try to look for the Menzer's index. Try to look at the subtle signs of hematological things. Try to get a good perfusion CT and see for splenic infarcts, all those things. After all these things, there is something called where there is no diagnosis at all. You will write like either IBS or functional pain or somatoform disorder. It could be because that we are not addressing certain kind. This is the last line. Anterior abdominal wall nerve entrapment syndrome. The cutaneous nerve getting entrapped in an abdominal wall can present to you with a very sharp pain. The patient will tell, inge valichite irukudana illa scanner negative irukku, this pain. And you give some painkillers, it will go away. For them, what we do is we give a tab block. Transverse abdominis block with an anesthetist, we give a lignocaine block, the pain will go away because we are blocking that nerve and it will go away. When you are blocking a parietal wall nerve and it goes away, that's an anterior abdominal wall nerve entrapment syndrome. That is one diagnosis. Another common diagnosis we can come across is abdominal migraine. Especially in children it's common, but I'm telling you in adults also it's quite common. Patients who are not sleeping well, not taking care of their lifestyle well, they do have this nausea, vomiting, abdominal pain. When you see them, they appear pale sometimes. It will be a very severe colicky pain, then it goes away. Then it won't come for a certain time. Then when they have exams or when they are going to have some interview or when they are going through some personal stress with husband or wife, then again they will have this severe pain with vomiting and everything, then they will come back to you. You put them on propranolol for almost 3 months, in those 3 months the pain will not be there at all. That is abdominal migraine for you. All the tests also will become negative because this is because of the vasospasm and intestinal spasm. And usually it's the stress, dietary factors, sleep, motion sickness and bright lights like a phobia, phonophobia and photophobia will be there for this. So this is my gist about an abdominal pain which I could tell you in less than 30 minutes. Open for discussion if you have any doubts. I still have 4 minutes I think.
Thank you Dr. Vishnu for the wonderful and elegant talk and greater clinical insights on pain abdomen. So we begin the schedule Vishnu and we are time constrained, close the session. Okay.
Thank you.
Over to host.